Question 1. A 10-year-old boy receives a transfusion of packed red blood cells. 3 hours later, he develops fever, chills, and flushing, but no hypotension, rash, or respiratory symptoms. Which of the following is the most likely cause? A. ABO incompatibility. B. Bacterial contamination of the blood unit. C. Donor WBC-derived cytokines. D. IgA-mediated allergic reaction. E. HLA mismatch causing GVHD. Answer C. Donor WBC-derived cytokines. Explanation. Febrile nonhemolytic transfusion reactions, FNHTRs, are due to preformed cytokines, e.g. IL-1, TNFi, released by donor WBCs during storage, not hemolysis or immune attack. A. ABO incompatibility causes hemolysis, flank pain, hypotension. B. Bacterial contamination leads to septic shock and severe symptoms. D. IgA reaction causes anaphylaxis, not just fever chills. E. GVHD is delayed, days, not within hours. Question 2. What is the best strategy to reduce the risk of febrile nonhemolytic transfusion reactions? A. Administer acetaminophen prior to transfusion. B. Use irradiated blood products. C. Provide washed red blood cells. D. Use leukoreduced blood products. E. Match donor and recipient HLA type. Answer D. Use leukoreduced blood products. Explanation. Leukoreduction removes donor WBCs, which are the source of preformed cytokines responsible for FNHTR. This is the most effective measure. This alleviates symptoms but doesn't prevent the reaction. B. Prevents GVHD, not FNHTR. C. Washing removes plasma proteins used for allergic reactions. E. HLA matching is for organ transplant or GVHD prevention, not FNHTR. Question 3. Which of the following clinical features most strongly distinguishes febrile nonhemolytic transfusion reaction from an acute hemolytic transfusion reaction? A. Headache. B. Flank pain. C. Fever. D. Chills. E. Nausea. Answer. Explanation. Flank pain is characteristic of intravascular hemolysis, as seen in acute hemolytic transfusion reactions, not in FNHTR. Both may present with fever and chills, so flank pain helps differentiate. A, C, D, E, nonspecific symptoms seen in both FNHTR and hemolytic reactions. Question 4. A patient develops fever and chills within 3 hours of starting a transfusion but is otherwise stable. Labs show normal hemoglobin and no hemoglobinuria. What is the most appropriate next step? A. Immediately give IV epinephrine. B. Stop transfusion and begin broad-spectrum antibiotics. C. Stop transfusion and send Coombs test and blood cultures. D. Continue transfusion at slower rate. E. Administer acetaminophen and monitor. Answer. E. Administer acetaminophen and monitor. Explanation. FNHTRs are self-limited and typically benign. Once hemolysis and sepsis are ruled out, treat symptomatically with antipyretics and observe. A. Used for anaphylaxis, not FNHTR. B. Only if bacterial contamination is suspected, hypotension, sepsis. C. Coombs test is for hemolysis. Not necessary if presentation is classic FNHTR. D. Not advisable until reaction is confirmed to be minor. Which of the following best explains why febrile nonhemolytic transfusion reactions are more common with stored blood? A. Denatured proteins stimulate antibody formation. B. Increased hemolysis of stored RBCs. C. Alloantibody production against donor leukocytes. D. Accumulation of donor WBC cytokines over time. E. Reactivation of latent viral infections in donor plasma. Answer D. Accumulation of donor WBC cytokines over time. Explanation. Stored blood products, especially those with residual WBCs, accumulate cytokines like IL-1, TNFi during storage. These are preformed inflammatory mediators that cause fever and chills, not a known mechanism in transfusion reactions. B. Hemolysis leads to different complications, hemolytic reaction. C. Alloantibodies are more associated with delayed hemolytic reactions. E. Latent viruses are not the cause of FNHTR. Would you